Join me in welcoming Dean Klag. He will first do his talk, and then we will have questions and answers. Dean Klag?
Thank you. Thank you, Sandra, for that very warm welcome. I really appreciate it. And I want to thank Dean Clark, in the back there, and for the hospitality and for inviting me down. And we had a wonderful conversation before, so I'm excited about being here. So I prepared sort of a general talk, and I know we'll have time for Q&A afterwards. If it's okay, if people have a burning question during the talk, is it okay if people ask the question? Okay, so I thought big picture. So as you move up the academic ladder, you become less and less specialized. We get these jobs because we're very specialized, but then we become less specialized. So I'm giving a pretty general talk. Wasn't sure who was going to be here, but there'll be lots of time, I think, for Q&A afterwards. So as dean, and I'm sure Dean Clark has the same thing, people ask you all the time to give talks about what are the big issues in health or public health. And many of us in this room probably have a list like this in our mind. This is kind of a list, and you can argue about what things are on here, but non-communicable diseases, right? That's a big issue now around the world. Lack of access to safe water, 1 billion people who don't have access to safe water. Increasing urbanization, the conglomeration of people in cities, emerging diseases. I was in Shanghai 3 weeks ago for a conference, and on Friday they said we're going to do a field trip. We want to show you the things that we do. So we're going to be going to the local CDC. And then I went home and turned on the TV and saw that they were slaughtering 20,000 chickens there the next day. And so we went to Sangjiang district and CDC where the outbreak of H7N9 was. So emerging diseases are always on our mind. Global warming, of course. There's people in the room interested in global warming and its effect on health. Emerging contaminants. So what we know is in our drinking water that none of our regulations are really designed to remove them. The disempowerment of women. If you look around the world, many countries have half the workforce doesn't have any power, has no autonomy. Natural disasters. That's a growth field as well. We're in the logarithmic growth phase. And then I put a bunch at the end. You could come up with 5 or 6 more, I'm sure. But if you look at this list, I think that fundamental to many of them is population growth and the growth in the population around the world. I'm going to spend some time talking about population growth. And when I became dean, 2 or 3 demographers from my school came in and wanted to talk, and they wanted to talk about the issue of population growth. And it was clear to me that it was the elephant in the room. When I hear all these conversations about these problems, very few people talk about population growth. Not to say it's the only problem, but it contributes to almost all of these. And we still have to deal with all these issues, but we took our eye off the ball when it came to population growth. So those of you who know, and the way I'm going to move through a variety of these topics, okay? And I'm generally going to mention a little history at the beginning of each one, and then talk a little bit. But a seminal development in the issue of family planning and reproductive health was the first international conference on population development, which was held in Cairo in September 1994. It was run by the UN. 20,000 people showed up. And it produced a steering document that became the basis of the Millennium Development Goals 4 and 5. And there was consensus reached on 4 goals: universal education, the importance of reduction in infant and child mortality, that should be a goal, reduction in maternal mortality, and that the access to reproductive health services for women is a human right, and emphasize that and sort of emblazoned it on the document. So that was great. So what happened? So this is a map. Usually you see these maps and it's about disease, and disease incidents. This is about funding, okay? So this is the change in donor assistance for family planning programs from 1996, right after the Cairo conference, to 2006. And you can see that the dark blue is per capita assistance increased, and then the rest are all declined, right? So what happened after that great seminal conference is funding went down. And it went down in the areas where it was needed most. Around the world, there was a reduction in funding. And why did that happen? Well, it happened in part, it was a political decision, and in part because the American administrations conflated abortion with reproductive health. and abortion with family planning. And you all know the PEPFAR story and ABC, and the bill that we had to mention that abstinence was the first, was the most important, or the first intervention to reduce HIV, that the Mexico gag rule that prevented us from anybody funded by the USAID to in any way advocate for abortion. And it was really started, Ronald Reagan was the first who passed a regulation saying that U.S. funds could not be used in any way to advocate for abortion. And then Democratic administrations removed that, President Bush put it back in. But that's why, this misunderstanding that reproductive health services were synonymous with abortion. So there was a political confusion here, but that's why it happened. So what happened? Well, when you pulled money out of these programs, people needed to work and have jobs, and by and large, most of them went to work in HIV programs. So let's take a historical view of population, okay? Talking about family planning. This is this is the imputed population of the world from the beginning of time up until recently, and you can see that up until about 1900, right, it was pretty flat, and then we entered a exponential growth phase, and now we're really up there. And if this were a stock, right, we would have bought this stock about 1900 or so. But we just celebrated in October, November, the theoretical birth of the 7th billionth person in the U.S. And so we are up here. And when you take this long perspective, right, this is where we evolved, how we evolved with the Earth, and this is where we are now. So back in 1804, we had about 1 billion people. And it took 123 years to double the population to 1927. The next doubling occurred in 46 years, 4 billion in 1974, and then we went from 3 to 6 billion over 39 years. And now you can see we're on this phase of about adding 1 billion people every 12 years or so. And that's good that it's only every 12 years, because this is percent change in population by time, and you can see that we grew at about 0.5% per year, and then here after World War II we had a baby boom, and then we had a baby boom right before World War II, and then we had World War I rather. Then we had Spanish influenza, and the rate of population increase went down. And then after World War II, it went up, and I was somewhere in this curve right here in the baby boom. And now it's sort of flattened out. Now it's going down. Now the population isn't going down, but the rate of change is going down. Okay. And this is the best estimates we have, and it's hard to make predictions about the future. But this is from the UN, and this is population growth. So you start back here in 1950, and then multiple assumptions here about growth and population. But the demographers at the UN feel that it's pretty certain we're going to have at least 10 billion people by the end of the century here, and that these assumptions, these higher fertility assumptions probably won't take place. So it will be about 10 billion people. So we're 7 billion heading for 10 billion. Now, I have the most white hair, I'm sorry to say, of anybody in this room. So I can remember what it was like. I was born in '52, in the 60s. Right? And in the 60s, there were a lot fewer people. There were a lot more farms. And when I went to visit my girlfriend in North Jersey, 12 miles from New York City in 1971, there were still farms in that town. It's amazing to think that now. So when you take that, so my personal life mirrors this growth and the growth we saw in the previous slide. But there's opportunities. So this is, I put the total fertility by country, and what this is a theoretical construct that if women of childbearing age experience the age-specific fertility rates in their country, how many children would they have? Okay, and you can see it goes from a low down here of 1 up here to a high of Niger of 7.2 children, right? And there's a broad range, and we're here around 2.0. Germany's about 1.4. This is mostly Europe over here. And I drew in, this is the replacement, that about 2.1 is what you need to replace the population. So you can see that much of the developed world is over here below replacement. Much of the low and middle income country are up here above replacement. And the U.S. is right about at replacement. And it's interesting, if you look at policies related to populations, Countries in the global north tend to have policies that try to increase population, either increase immigration or ways to increase fertility. And these countries, of course, have policies in the opposite to try to decrease fertility. So here's the same data in a different way in a map, an estimate of total fertility, and it goes from purple, from 0.8 here, and here's replacement right about blue, and then over here we have 5.56. And so you can see that when you look at the map, the areas of high fertility around the world are in sub-Saharan Africa. So that's where we need to work, and that's where there's opportunities for reducing population growth. And in some of these countries, I go to Uganda pretty regularly, and the difference in just a year that you see in Uganda because of population growth, it's just phenomenal. So it's changing the world. So getting away from the socio-political aspects of family planning, why should we do it? Well, there's two reasons. One is the health of children, and the other is the health of women. So these are data I took from a publication from Bangladesh. And this says inter-outcome interval. That means if you take two pregnancies and whatever the first outcome was, whether it was a therapeutic abortion or a miscarriage or a live birth or stillbirth, versus the outcome of the second pregnancy, so any outcome. And this is by months, so less than 15 months, 15 to 18, 18 to 23, and you can see. And this is relative risk. Okay. So what do you see if you use one at 3 years as the interval pregnancy as the baseline? What do you see? Well, just concentrate on the blue here, the blue squares. But you can see that if the interval between pregnancy outcomes is less than 15 months, you have a twofold increased risk of the child dying. That's not within the first month of life, but after that, between the first month of life and 5 years. So what you see is that as the interval between pregnancies gets shorter, the risk gets higher. So here over 2, there, twofold increased risk of the child dying. Here about 1.75. So one reason to do family planning is to space pregnancies, right? So that you can make sure that you have a longer interval and you have healthier children. So why does this happen? Well, we don't know. People talk about maternal depletion, but you can imagine, and you see this when you see nursing mothers. Some of these countries, in Bangladesh, the best food, of course, for children is breast milk. There's no safe water, and if you have 2 children on the breast and the third child comes in, then somebody's getting left out. So birth spacing is important for healthy children. And the other thing that's when you look at the data is very striking is that the best intervention we have to prevent abortion is spacing of children. So this is again data from Bangladesh. This is yellow here, it's hard to see, but that's the line for abortion, this is the line for miscarriage, and this is stillbirth. And this is inter-pregnancy interval, and these are odds ratios. So you can see that if you become pregnant within 6 to 8 months after, less than 6 months after your last pregnancy ends, you have a 10-fold higher risk of getting abortion. And if it's 6 to 8 months, it's 4-fold, and it goes on like that. You can also see that outcomes for the mother, miscarriage and stillbirth, are also higher with the shorter interval. So health of the children, the newborn, is one reason to promote family planning. What about health of the mother? This is from a different study in Bangladesh, but this is where the ICDDRB is the International Center for Diarrheal Research in Bangladesh, and they had population-based interventions. And what they did is over a 30-year period, there's 3 10-year periods here, they compared maternal deaths in their area over time to a government service area, where also women were getting better services, but there are more intensive services here. And what did they find? Well, if you look at this, maternal mortality here is about 400 per 100,000, so about 4 per 1,000, and it goes down to about 200 per 1,000. So over that 30 years, it fell by half, right? And in the black bars here are abortion-related. So that 97 deaths here, 20 deaths there, a 79% decline in rates of abortion-related deaths. So here you see that availability of reproductive health services, a whole variety, resulted in a reduction in overall mortality and a reduction in abortion-related deaths. And when you look at the government service areas, you see the same trend, but not nearly as marked. So a 48% reduction here in mortality in mothers versus a 79%. I said 79% reduction in abortion, but it's a 79% reduction in total mortality. Okay, so that's another reason for family planning, right? So health of the mother. Now, a third reason, now I'm talking to you about this, obviously, if you're in the School of Public Health, you by and large probably know this and may feel the same way. But a third reason to promote family planning is that women want it. And this is data from around the world that I took from the UN. And so limiting, this is asking women of childbearing age who are in a stable relationship whether they want access to family planning services and whether they have it. So this is a percentage of the population that has an unmet need. The yellow bars are for limiting pregnancy. They don't want any more children. And the blue bars are for spacing. And if you look around the world, there's about 40 million women who don't have access to family planning services, who want access to family planning services. So and I'm happy, you know, one of the things as a dean, you take, people ask me what I do as a dean, and I say I actually don't do anything, but I help my faculty do things. And so our faculty, one of the great things they've done is to have the second international conference on family planning. So I told you the first one was in 1994, I think, in Cairo, and the next one was 15 years later in Kampala. And what they were able to do was to get the First Lady of Uganda, Janet Museveni, to come and speak. Now, Janet Museveni had never uttered the words family planning in public because her husband believed strongly that for economic growth, you need as many children as possible. And here's what she said at the keynote. She said, family planning needs to be promoted as a key strategy in reducing maternal mortality. And then she went on to talk about that we know that women who have smaller families and access to family planning have more resources, more economic resources, and make better decisions for the family. So I just use this as an example that in academia what we try to do is write papers and get grants and pay our salaries. But taking that evidence and using it to make change is really important. It's harder when you're an assistant professor than when you're a full professor, but that advocacy is how we change the world. Okay, so let's just move on about another factor that's influencing health trends. And this is another, this is a success for everybody who's involved in public health, and this is childhood mortality here for the world, and then you can see for South Central Asia and Sub-Saharan Africa. So overall, there's been a marked decline in child mortality. Why is that? That's because of the expanded package of immunizations, better nutrition, better safe water, so market reduction. And it's been less so in Sub-Saharan Africa, but going in the same way. So big reductions here in deaths, under 5 deaths, from 230 down to about 40 or so. Not to say that that's adequate. We still need to work more, but we've had a big impact. And so what does that mean, that reduction in under 5 mortality? Well, you know, under 5 mortality is the biggest driver of life expectancy. So here's data from the U.S., 1900 to 2040. And if you looked at mortality back in 1900 in the U.S., it was 49 for women, 46 for men. And what happened is in the pre-antibiotic era, as we controlled disease, improved nutrition, decreased crowding, you saw a marked increase in life expectancy to over 70 for women and about 66 for men. Right? And that's what I just showed you, the reduction in child mortality. That's what drove this. More recently, as we've gotten child mortality reduced in the U.S., what we've seen is an increasing, a slower increase, but a progressive increase in life expectancy. And that's really due to lengthening life at older age. So look here, if you got to, this is, these curves are, you know, life expectancy at birth, right? These curves are life expectancy in men and women at age 65. So back in 1900, if you got to age 65, you had a very good chance of living to be 77, 76. But what's happened is life is now life is being extended. So if you get to 65, your life expectancy now is 84 if you're a woman, 80 if you're a man, and that's because a whole variety of things. Improvement in medical care for sure, but also improvement in lifestyle and prevention. So these two trends, the reduction in under 5 mortality and then the lengthening of life at older age, means that life expectancy is greater, right? And we know that in populations where under 5 mortality goes down, fertility goes down, because women don't feel like they need to have 5 children if 1 out of every 5 dies. And so here's what you see to population pyramids, and this is China, right? So China went from the classic population pyramid to a population monolith, right? And they have the lowest, as I showed you, total fertility rate in the world. But this is what we're seeing across countries. It's, you all know it as the epidemiologic transition as we lengthen life, right? Now, one question you might ask is, so if people are living longer and to older ages, are they healthier? And I have to say that the jury's out on this one. There's data both ways, but I'm going to show you some data, and this is just from the U.S., and this is from national surveys, and this is both sexes, men and women, and I think just focus on the bottom bar, the clear bar, which is active life expectancy. So what you see from 1992 to 1997 to 2002 in both men and women in this study is that the percentage of people who are living active life expectancy without disability is going up. Okay, so that's one piece of evidence that people are getting healthier. There's some other data that aren't quite as good as it, but might suggest otherwise. But I think overall, people are probably getting healthier. So that's a trend that's going to be influencing health, right? People are living longer and living to older ages. So what does that mean? Well, that's what's behind the shift in mortality in the U.S. So this is, you probably saw in the Lancet the burden of disease study just in January, I think. I find that study, the graph, so difficult to read that I'm using an older study, which I think, which is from Jerry Anderson from our school, but this was in the New England Journal. And what he pointed out, this is mortality in 2005. So if you look at here deaths or disability adjusted life years, and you look at the causes, communicable diseases are in these light gray bars, and you can see that around the world, the leading causes of death are no longer communicable diseases, right? They're cardiovascular disease, cancer, and injuries. And if you look at disability-adjusted life years, mental illness and injuries lead the pack, and they do that because they occur in older people. Okay, so that's not to say these other things have gone away, right? We still have HIV, we still have tropical diseases, we still have infections, but the majority of deaths now are due to chronic, non-communicable diseases. So we can't stop doing all the things we have to do for infectious diseases, but we have to recognize that our mission has to be broader. Public health grew out of infectious disease control. We're not really good at looking at chronic diseases, especially preventing chronic diseases like cardiovascular disease, because to do it, it really involves new collaborations with clinicians and healthcare systems, but it's something that we have to take on. Another issue I think is going to be important for the future is food security. So this is another history slide, and much of this occurred before many of you in the room were born, so I think it's worth going through. But in 1967, the U.S. president, a science advisory committee said the scale, severity, and duration of the world food problem are so great that a massive, long-range, innovative effort, unprecedented in human history, will be required to master it. It was really, we were looking at huge famines across the world. And two foundations, Rockefeller and Ford, took the lead in establishing an international agricultural research system. And I never really, I've dealt with the Rockefeller Foundation since I've been dean, and I didn't understand until I read about this why they had such an interest in agriculture. But they were the ones that were behind the Green Revolution. So they did several things. So by using selective breeding, they developed new varieties of wheat and rice that could produce fruit sooner, produce seed sooner, and then you could go from one crop a year to two crops a year. And then the use of inorganic fertilizers and modern pesticides. So this is just some example. Historically, we did selective breeding of wheat, and the yield increased from fourfold over 1,000 years. But in 40 years, they went from 2 to 6. They tripled the yield. Okay, so a huge impact on productivity. And this is a man, Norman Borlaug, who was a hero of the Green Revolution. So he developed these semi-dwarf varieties of wheat. So they didn't put a lot of effort into growing long stalks, and then disease-resistant and very high yield. And he's credited with saving 1 billion lives. He won the Nobel Peace Prize, the Presidential Medal of Freedom, Congressional Gold Medal, but not somebody we talk a lot in public health. Talk about a lot. So I like to think that this technology saved our lives. It really prevented famine in India. And so we've seen, and I should mention too about rice in agricultural research centers in the Philippines is where they developed the rice. It could be that's a dwarf high yield rice. We haven't seen these kinds of productivity in Africa in terms of agriculture, and I think there's lots of reasons for it. One is there's different climate, different soil, but obviously there's socio-political concerns as well. And it's fun, we call this the Green Revolution. They called it that in the 70s. We wouldn't call it that now because it's not organic, right? It's using pesticides, it's using fertilizers, and it's using a lot of water. And so the question is now, is this sustainable? Are we going to continue to be able to do this as the population grows? Are we going to be able to feed the 10 billion people we have to feed by the end of the century? And then when I think about exports, those of you who go to China know that McDonald's is not the #1 export. It's KFC, right? You see KFC everywhere, but McDonald's as well. And so what we're exporting now is our diet, which is a calorie-dense, high meat diet, and obviously it's not healthy, and it is amazing when you go to China now. I went to China the first time in 1994. Everybody rode bicycles. Everybody was thin. They had BMIs of 19, and now they're not. And so it's not a healthy diet, but a meat-based diet's also not very efficient. So here's some data from the Water Footprint Network, and this is the number of gallons of water required to produce a pound of beef, pork, chicken, soybeans, wheat, and corn. So obviously the cow has to drink water, but that's not where most of the water is used. It's used to irrigate the fields to produce the grain that the cow eats. And so if you look at 1 pound of beef requires 8 pounds of grain, and you have to water that. But if you look at down here at grain, we cut out the middleman. It's much more efficient in terms of water, right? To eat vegetarian than to eat beef. Now I eat beef, I'm not saying, but if you look at whether we can continue to do this, and in fact we are exporting this diet to the world, it doesn't make sense from either a health or an ecological point of view. So another pattern that I talked about in that first slide is urbanization, and what's happening there. Well, the bottom lines are for developed countries back to 1950 or so, and you can see back in 1950 in developed nations, about half the population lived in cities, and about half lived in rural areas. And then we've seen this increasing, steady increase in number living in cities. So we were talking at lunch. These are the Democrats. These are the Republicans. But we've had this spread for a long time. But until last year, most of the people who lived in low and middle income countries lived in rural areas, and there's been this rapid urbanization, right? So these are rural areas. This is this rapid urbanization. So now more than half the population of the world lives in cities. So what does that mean for the future? Well, if you look back to 1970, in 1970 there were 2 megacities. Megacities defined as a city with a population greater than 10 million. Tokyo, Japan had 23 million, and until I prepared this talk, I didn't realize that New York and Newark were in the same SMSA, because New York never mentions Newark when they talk about it. Newark's always talking about being in the metropolitan area, but from the Census Bureau point of view, they are. So there were 16 million people there. And then in 1990, fast forward 20 years, we have 10 cities. So Tokyo is now up to 32 million, New York 16 million, but you can see all these other places, Mexico City, Sao Paulo, Mumbai, Osaka and Kobe, Kolkata, Los Angeles, Seoul, and Buenos Aires. Now what about now? Well, now we have 23 cities that have over 10 million, right? That's a big list. And what's going to happen by 2025? We're going to have 36 cities that have over 10 million people. Now, a city with 40 million people, that's hard to get around, right? And Beijing, I have friends in Beijing who now, have apartments that are beyond the third ring road. It takes an hour and a half, 2 hours to get to work. So they find some place to sleep close to the hospital, and then on the weekends go to their apartment. So we have this expansion of megacities. But it's interesting, if you look at projected growth, most of the population in the coming years is not going to be living in megacities. It's going to be living in towns, smaller cities, less than 500,000 people. So this is 3 time points: 1970, 1990, 2011, 2024, 4 time points, and you can see the growth in small cities here. And then these are the mega cities. They'll be very big, but they won't have nearly the population distribution that the smaller towns would. So as we think about the future, and we spend a lot of time thinking about mega cities and how we deal with mega cities in the future from both a health point of view and from an environmental point of view, but we really have to be dealing with these smaller cities as well. And it's interesting. There are health benefits and risk of being in cities. So if you look now in the world, about 1 in 3 people live in cities. So 30%. It's 1 billion people. I'm sorry, 1 in 3 live in slums. 1 billion people worldwide live in cities. And having seen this happen in Taiwan over the years, one of the first things you see is people switching from human locomotion to using motor vehicles. And in Taiwan, when I first went there, there were no limits on how many people could be on a motorbike. You're wondering why I do this. So I used to see like 6 and 7 people on motorbikes, where you'd see the father driving, a 5-year-old standing and a 4-year-old in front of them, and kid in a basket, and the mother behind, and then kids on both shoulders, and it was amazing. And luckily they don't do that anymore. But so the causes of death and disease shift when people go to cities. Urban air pollution is a huge factor, and indoor air pollution, which I don't have on here, is also a big problem. TB incidence, because of crowding, is much greater in cities than in rural areas. It's 4 times higher in New York City than in rural areas. And in the Congo, 83% of people with TB live in the cities. The other thing that happens is that living in a city, you get less physical activity than in a rural area, and you eat a more refined diet. So we did studies years ago in China showing that if people moved from a rural village to a town, and we looked at people who had been there for 5 years, they had much higher levels of blood pressure, much higher levels of adiposity, higher levels of cholesterol. So living in a city is, from a cardiovascular risk point of view, and diabetes is much less healthy. And in fact, in India, for example, the prevalence of diabetes is much higher in cities than it is in rural areas. But provision of services, both if you want to deal with effluent and waste, and it's much more efficient to do that from an environmental point of view in cities, and providing screening and healthcare are much more efficient in cities. So there are some advantages to cities, and if you look at screening programs for infectious diseases, much more cost efficient to do that in a city than in a rural area. Now, we talked at lunch a little bit about inequities and income inequality. So I just want to show you some data. And this is from India, and this is from 1986 to 2001. And this is an index of per capita consumption. And so this top bar here is urban top 20%. And these 2 bars here, that's the rural top 20% and the urban next 40%, right? And then down here are the urban bottom 40%. And then this is the bottom 80% of the rural villages. So in India, huge inequities. Those of you who've been to India know that. You can see that. And if you look at a measure of inequities like Gini coefficients, this is change from 1990s to 2010. And what do you see here? So this is no change. Okay. So in Brazil, they've gotten lower, which means less inequities. But look what's happened in China. China, big increase, 8% increase in urban areas, rural areas, Hong Kong, India, rural. And again, we have programs. It's not that I like to travel. We have programs in about 120 countries at our school, so I have to travel a lot. And this just hits you in the face. I was in India in January, and I saw a private residence that was 24 stories high. I mean, it's just phenomenal, the accumulation of wealth in both India and in China at the top of the economic pyramid. But we don't have to look in Asia. We can look in our own country. So this is data from the CBO, and the way they express this is distribution of $100 per person. So this is $5 here, $10, $15, $20, and this is the top 1% of the income distribution in the U.S. And you can see how one, the inequity is going up, but how much more they have in terms of the distribution of per capita income than the lower bars. This is the top 1% to the top 5%, and then farther down. So although we see inequalities in developing, especially in countries that are moving to middle income, it's getting worse here as well. So we don't have to look that far. I put this in. This is a picture from Amsterdam. It's a falafel shop, but it says here, care about your citizens, health care for all now. And this was in the middle of the debate here about Affordable Care Act. And just to point out that another trend, I don't have data on this, but I've been in 15 countries since November, and one thing that always comes up when I talk to people, whether it's wealthy donors I'm trying to get money from, which I never do, of course, but wealthy donors, or whether it's industrialists, or whether it's people in the health sector, everybody's concerned about healthcare and improving the quality of healthcare and increasing access to healthcare. It's true in every country. It's true here, right? But it's true in every country. And this is a huge trend which we're trying to get our arms around in this country, but it's true throughout the world. That as people's income increase, they want access to healthcare, and they want access to better healthcare. So that's a driver for the future. Now, nearing the end here, we have to talk about climate change. So this is two pictures of the Riggs Glacier in Alaska, taken from approximately the same spot, 1941, 2004. Now, and so this is an example of melting of glaciers. Now, those of you who know more about climate change than I know that this varies a lot by region. It varies a lot by the kind of glacier, whether the glacier slides easily, melts faster. We know that Antarctica doesn't appear to be decreasing, but scientists have documented around the world decreases in ice. And this is the paper that I think really made the argument most strongly and changed many people's thinking about global warming. So this is going back to the year 1000, and what you see here is the black line is the mean. This is taken from ice samples, rock samples, trees, things like that, trying to estimate what the temperature was. So the black line here is the mean, the gray line is uncertain. This is the regression line here. These are the mean temperatures, and then this is the uncertainty. And it shows that one of the problems with the argument and debate about global warming is that unless you're comfortable with the notion of variability, you can't really understand global warming. And because we know that reframing the debate in terms of rather than global warming as climate change, I think was a wise thing to do. But you can see that the mean was going down here until about the Industrial Revolution, and then it's gone up markedly. And that documentation of change really, I think this article was in Science, really brought the argument to the fore more than any other paper. And there's more recent data from NASA, and one of the problems of course, using data from earlier than this is, the methods of measurement were just much more indirect. But you can see whether you look at the annual average or the 5-year average, we're on the uphill climb. And there's been now, I think for the U.S., it was amazing to me. I don't know what you all think, but Hurricane Sandy, it brought home to everybody on the East Coast that global warming is real. I don't think anybody on the East Coast argues now about, is there a change in climate? Are we seeing superstorms? Sandy answered that for us. But it's interesting that, obviously due to greenhouse gases, that the villain in this is us. So we win the prize for being in the high emission countries, right? And you can see around the world much lower emission countries in Africa, parts of Asia, and in South America. But if you look at the estimated deaths attributed to climate change from this report, it's the reverse. We don't pay the price for climate change. It's the countries that produce the fewest in the way of greenhouse gases who are paying the price, and are going to pay the price even more in the future, because they're going to be very sensitive to any changes in rainfall that affect agriculture. But what we care about as public health folks is the health effects, and there's been some work done on this. It's hard to estimate, but I took this from the IPCC report, and what they punted somewhat, right? They didn't give estimates, but they gave confidence levels in these predictions of the health effects. So going from high, very high, high, moderate, low, and moderate. But an increase in malnutrition and an effect on child growth and development, an increase in death, disease, and injury from natural disasters. Felt mixed effects on malaria with some expansion, some contractions, and then change in the range of some vectors of infectious diseases, very high confidence. And we've seen that already in the U.S. When, was it last year that we found dengue in Palm Beach County, Florida? And I thought, well, finally, we're going to have a lot of funding to look for, to create a dengue vaccine once you get dengue in Palm Beach. Increase in diarrheal diseases, increase in low confidence in this, and a decrease in food productivity. And this is going to be, this is a critical issue as the world's population increases. So now I'm going to end, I'm going to end talking about technology. And there's lots of things we could talk about here. mHealth, I mean, it's amazing what we can do with mobile health technology. The availability of techniques to look at big data, and we're getting inferences we couldn't, and we're collecting more data than ever before, whether it's in medicine or public health. Informatics, Obama's administration push to have electronic medical records means that we're having unprecedented amounts of data. Understanding the microbiome, that's important. Gene therapy, we can now manipulate human embryos to do gene surgery. And then lastly, disruptive technology, things game changers that we don't even know are going to happen now. But I just want to talk about one that I think is so cool. And that's the use of bioprinting. And there's several different mechanisms to do this. Here's three. Laser writing, inkjet systems, or extrusion-based deposition. So what does this mean? Well, this is where you take the cells from an individual, you grow them in culture, and then you create an ink, right? And then you print things. And I should have asked whether we have internet access here. Do we have internet? Oh, we do. Okay, so this is how do we click on the boot? Do we have a keyboard? How do I?
There's a keyboard here.
Yeah, how do we? Oh yeah, there we go. I'll just show you. This should take a minute. This is really.
Does it work?
I don't know. I don't see an arrow. Do you see an arrow?
Yeah.
The arrow disappeared. Yeah, it's on there. Yeah.
You see it?
Yeah. Try that. Nope. That's
No?
okay. Where's the tech support when we need them?
Yep. Good question.
I don't see an arrow.
No, I don't see it either.
Okay. Well,
Okay.
I'll go back.
What we can do is click out of that maybe and see. All right, let me ask Joey to come in.
Yeah, we need. Anyway, so what I was going to show you was this is an inkjet printer that's been loaded with chondrocytes from an individual who's lost his ear, and what it does is it prints an ear. It creates a 3D model of the person's ear. They scan the other ear, and then flop it and create. Yeah. Can you click on that? Is that possible?
Sure. Everybody think of your questions.
Okay. Anyway, so and then when they then put it in culture and let it grow, let the chondrocytes form links, and then they have an ear, and then they grow skin on the ear, and they transplant it onto people. And now they can do this with hearts. They can create beating rat hearts, right? And a variety of other organs. And
are we past this part?
no, keep going. And the prediction is that in 5 years we'll be able to print kidneys. And because it's the individual's DNA, there's no rejection, right? Now, biomedical engineers have been using scaffolds to create structures, but this doesn't need a scaffold, right? This is just you basically use a CAD program to print the ear. You can turn the sound off. Okay, good. So, okay, but now okay, good. So anyway, it's pretty amazing. And at the end, the guy holds the ear. He has an ear there. So. Okay. This is being done at Cornell. But if you go to how do I get out of this thing now? Guy, come back. Okay. Okay, here we go. So I got it. So I'll just go to the end here. Okay, so here we go. All right, okay, and yep. What?
Left click, and we'll go to.
Okay, good. Anyway, so and you can do the same with blood vessels. So this is a way to print blood vessels where you take intimal cells, put them in a ring, pile it up, and then you take vascular smooth muscle cells. So I think this is one game changer. So what did I say? So in the future, the world's going to be, there's going to be more of us, we're going to be older, we're going to be more obese, feels like me, more urbanized, and we're going to have more inequities. And I didn't give many examples, but all these trends are going to impact poor countries more than rich countries. And that population growth it contributes to all these problems and is fundamental in some of them. And we need to depoliticize that issue. Talk about climate change, we talk about technology, and there are going to be game changers we can't envision. Just like the Green Revolution, we were predicting, Paul Ehrlich's the population bomb in the 70s. Millions and millions of people in India were going to die. It didn't happen because of game-changing technology. I don't think we can count on game-changing technology, but we have to keep it in mind. And then I talked about demand for healthcare, but didn't talk about maldistribution by geographic area, both within the U.S., rural, urban, and around the world. And by medical specialty, there's huge issues. So what to do? So I've been thinking about these things a lot. So I just had to pick a new chair. I put his picture up here. It's David Peters for our Department of International Health. I'm thinking, so where does international/global health go? And so David is a great person, outstanding leader. But what he works on are complex adaptive systems. And if you know this from the engineering literature, looking at very complex systems and then modeling them so you can make predictions, I think that's where we need to go in public health. We need to put a lot more emphasis on systems, whether it relates to biological systems or to health systems, right? And that looking at all of these in isolation, we're just not going to be able to do it. And I can talk about complex systems, but I think my time is up. So thanks for your attention. Yeah, is our time up or?
No, you're good.
Oh, okay. Sure, I'd be happy to answer questions. Stephen? Yeah.
Well, first of all, just thank you for a fascinating conversation
You went from infant mortality to climate change
Yeah.
for our students, and you're all this is a part of public health. Comment and question. Comment is, the technology you just showed about how to make an ear, print an ear. That same technology is being used to print gun parts.
You can go to the internet and download the plans to print a plastic gun. Yep.
And eventually you'll be able to literally print a gun in your home from a printer.
Yep.
So the issue of values as it guides, this technology is one concern. The other has to do with infant mortality. Bring us right back to the U.S. Report, front page New York Times. 12% decline in infant mortality in the United States. 16% among black women. In North Carolina, 20% decline improvement. So these are all really, really great. But nowhere in this story is a school of public health mentioned. Nowhere in this story is public health attribution to the success mentioned.
Right.
So my question is, for those here in the room and their future careers, where is public health going to be in this new kind of trajectory
Yeah.
you laid out? Can we just as easily be over in the engineering school
Yeah.
or in the climate school?
Yeah.
What is the unique contribution of public health?
Yeah. Do you want me to answer that, or do you want the students to answer? Or? Well, I mean, I would say that it's health, right? So what do we do? One of the things that makes it so hard to explain to people what we do is so broad. So when I do the orientation for students, for our new master students, I start out by saying, now I'm going to teach you what to say at the next cocktail party when somebody asks you what is public health, right? And because it is hard to explain. But if you look, so I'm pretty optimistic about public health. If you look at the growth in public health programs, schools, students, it's just taking off. Part of it is because people understand we do global health. But for all these things, so what's our contribution? Our contribution is understanding populations and understanding and how to measure population outcomes. And then whatever exposure, whether it's a clinical trial, a treatment in clinical trial, or whether it's global warming, or whether it's contaminants in water, whatever exposure you want to look at, we figure out a way to measure it, and we look at population outcomes. And then we figure out a way to prevent the bad outcome. I think that's what we're good at. We're good at prevention. We're good at understanding populations, measuring population health. That's, if you scratch all of us, that's the core thing we have. And it may be that what we care about are social inequities, and that's the exposure, or it may be that you care about water quality. But I think that's what we do. And the dean at Arts and Sciences said to me during one conversation, well, you do everything then. And I said, yeah, we sort of do everything. But we do it, but it's health. That's what makes us different, and that's at the heart of our discipline, I think. Yeah.
Hi, I'm Bonnie Braun. I'm a professor here at the school. And I've quite a bit of what you talked about had to do with food and food security.
Yeah.
You mentioned Norman Bartling. He's at was at Land-Grant University,
Yep.
also in an urban area. We're at Land-Grant University.
Right.
We have a College of Agriculture
Right.
and Natural Resources. There's at your school, our school, and you've laid out a picture of the world and its needs. And you said public health has something to say about population and health.
Right.
Jointly, though, we could say something about the health through the food systems,
Right.
the complex systems and so forth. Have you given any thought to going beyond sort of the boundaries of public health to this more interactive set of boundaries that we have right here in our own state?
Yeah, so I think, so people who do public health like to solve big problems. And you can only do big problems if you collaborate, right? It makes us naturally collaborative. And we have this group that does we have a Center for Livable Future who works on, factory farms and a whole variety of things. I mean, it's amazing what I've learned being dean. As a physician, I used to worry about overprescribing antibiotics, was like creating drug resistance, but then found out, through Ellen Silvergeld and people at our school that in fact it's, all the chicken farms in the Eastern Shore where there's antibiotics in the chicken feed, and the groundwater has drug resistance, the creeks have drug resistance. And so I think being at a land-grant university, it's a big advantage, because I mean, we have to create this little group, but you got an ag school here, basically. And the other thing that we really need that we don't have that would be great for public health is a vet school. Because when you look at emerging diseases, right, emerging diseases are really, there's some other species diseases that have decided, that have figured out. And so I think you're right. We'd love to work together.
Well, we do have a vet school. It's a regional school between Maryland and Virginia.
Yeah, but the clinical part's down in Blackwater, right? Isn't it?
Blacksburg.
Blacksburg. Sorry. Yeah. But it would be great if Maryland had a complete vet school here. We've tried to work with vet schools. It hasn't worked well. But if you look at all the stuff on emergency, so I agree. And land grant universities, if you look at I know a lot about the different schools of public health because I was chair of the ASPH, and one of the problems with chairing that, it's not a problem, it's fun, but the heterogeneity of schools. So every organization belies our origin. So some schools started from medical school, they have a very biomedical model. Some start from schools of social work, and they're heavily involved in psychosocial issues. So some grew out of health departments. They're totally practice oriented. So it's really different. But we all come, so that's why I thought, what makes us public health? It's really prevention, population, and figuring out interventions based on measuring outcomes. But we would love to. Do you guys do a lot with in agriculture here?
Well, we do some.
Uh-huh.
Some of us actually have an appointment with Extension over in the College of Ag.
Uh-huh.
We have some joint appointments, but there's a lot more that could be done.
Mhm.
And I was just curious. Food security, for example, you talked about global level, but there's also quite a bit of food insecurity right here in Maryland's population.
Yeah, that's for sure, especially in the neighborhood around our school.
Yes.
And so we do have people who work on the issues, with corner stores in Baltimore and policies related to food. But it sounds like it would be great if you could come up and. Do you know Bob Lawrence and those folks?
No, I know of him, and I know of the center.
Yeah, maybe come up and meet everybody. Or they could come down here and meet everybody. Or we could meet in Columbia. Yes.
Great talk, and
Thank you.
I just want to comment on another elephant on the room, and that is lack of communication, our inability to communicate. And the example is going back to your climate change. We have a warehouse full of data on that, but yet more than half of the population do not believe that climate change is real.
Mm-hmm.
And this is not, I'm not talking about population of Burkina Faso, but of United States.
Mm-hmm.
And then you have a governor like in Virginia who is basically chasing the guy working on climate change out of the state, and he's in Penn State now and still trying to access their email, and communication.
Right.
Sort of like going after individuals who work on this topic.
Right.
So I see a utter lack of communication on the field of public health. How do we, put this message out there to the general public? And I think maybe that's one area there has to be focus, focus from the School of Public Health.
Yeah. So I think you're right. I think communication is important. I think as I was reading about stuff for this talk and trying to think why have people been so resistant to climate change? Well, one is growth and business is good. That's it's this economic argument that's very threatening. But the other is, I think, because of the variability that people, we take courses in biostatistics. We get an appreciation for variability. We understand that mean line, there's a lot of variation around it. I think that was one of the problems with climate change. I was at a talk that some guy from a professor came from the Max Planck Institute came. It was chilling. It was just chilling about. It's irreversible. I mean, it's just it's something. you know, there's so many things we have to work on, so many things. But when you sit down and think about climate change, you think you should be really storming the ramparts on this one. You know, you should be marching in the street with torches. And what I predict is going to happen is, you know, it's really we're going to get to the point where we have to do something, and so it's going to be the curative model rather than saying let's stop using fossil fuel. I mean, that's the solution, right? Stop using fossil fuel. People are going to do planetary engineering. You know, they're already working on it. How do you put enough particulates in the matter, particulate matter in the atmosphere to block sunlight so that you reduce temperature? That's what's going to happen. People are they're not going to want to do the things, the conservation and backing away from fossil fuels. But you're right. So communication, you know, in science, I think, when I was an assistant professor, I felt my responsibility was to write papers and get grants and fund the people who worked for me. And it's true, it was, but nobody ever talked about advocacy, and advocacy is really important. So not communicating to your peers, but communicating to the broader population, and the better we get at that, the less disasters we'll have. But by and large, and I try to make it. I write about advocacy at our school. I try to encourage it, but that it's not part of academia. Yeah.
I would like to ask a question. I remember, and this is in connection to both of the topics you have brought, and how about a trailblazer like C. Everett Koop? We all remember C. Everett Koop who recently passed.
Yeah.
And the role that he played under his position in the public health service.
Yeah.
When was the last time that we had a C. Everett Koop, someone who put public health in the face and the ears and the eyes of everyone? And maybe that may be a way for us to identify an individual as a public health, head, to be able to tackle all those areas, not only environmental health, but also even veterinary medicine. I mean, that's an area that I find interesting. My background is a combined medical research and public health. And how do you get to, public health individuals who talk to the scientists? Well, you use animals to do medical research. It's just, beginning to converse about the understanding of the respect of the subjects and the importance of what you do. But again, where is our next C. Everett Koop? Would that be the answer?
Well, I think, so it's interesting. So C. Everett Koop was a professor of pediatric surgery at the medical school where I was a medical student. And so I was a medical student when he was selected. And, he was seen as a very conservative person. And he was really, he rose to the challenge, but it was really the Reagan administration who, he had to make a decision whether he was going to speak the truth or not. And he did. And now I think the role of Surgeon General has been really constrained.
Because of it.
Yeah. And so, the fellow I'm blocking, who was, Carmona, the way he talks now about how everything he had to say was vetted and he was really not able to speak. And so I think, I don't think that person can be a C. Everett Koop. You have to admire C. Everett Koop for his courage, right? I mean, he spoke against type in many ways, but he did what he thought. Luther Terry, will there ever be another Luther Terry, or
David Satcher.
or David Satcher, Lewis, Bernie, Leon Bernie, who was the first Surgeon General to mention a link between cancer and cigarette smoking. Yeah, I don't know. I don't think it's going to come from the Surgeon General, because I think you get vetted. If you're going to do that, you get vetted out. Yeah.
So we need to identify what we will take, or who would be that institution.
Yeah. Well, I think the great thing about public health is that we believe in crowds, right? I mean, that's what we do. And so if you look at this latest statement about polio eradication, where the fellow in New York got all the deans to sign, got 500 leaders to sign on to this petition, and it really did result in increased funding. I think we're going to see crowdsourcing. We're going to see the use of the internet. It's just Sierra Coop made that announcement when there were 3 network TV stations, right? And we don't have that anymore, so it's got to be a different strategy. But it's got to be people in public health who step up. Yes.
I'm going to reserve the right of the last question.
Okay.
Oh, I will do the last question. I will give the last question to a student,
Okay.
but it will be our last.
Okay. So, my name is Monique Thorin. I am a senior community health major here, and I'm hearing all these comments about collaboration and communication. Who's going to be this voice or the face of public health? And I really think it's going to be the students who are in school now. And I mean, even undergraduate students that I know, I'm in the Gemstone program here, just defended my thesis, team thesis on self-efficacy and the effect on the home nutrition environment of SNAP and WIC shoppers in DC metropolitan area farmers markets. And you hear about all this great research going on, but what's next? How can we get these student voices to the next step? I mean, when we were defending our thesis, our experts asked us, what's next? What are you going to do with your results? You found that self-efficacy improves the home nutrition environment. Where are you going to go with this? And it kind of struck me because I was like, I really don't know what to do. Like, where do I put this information? Who do I go to? I mean, we all know you can write manuscripts and get published, but how do I get this to the lawmakers? How do I get this to affect real change, something that is tangible? How do I get policy made? How can we create a path for students where we can take research and take these voices that need to be heard and get them out there? Is really my question to you.
Yeah. Well, so the first thing I would say is you have to be a little careful because you do want to get your degree, you have to balance. There's very few people who early in their career can spend a lot of time on advocacy and do the academic thing. And because for you to make the kind of change you're talking about, you're going to need a degree and you're going to need a track record that gives you credibility. But it makes me think, we don't really have, we have the APHA, but it's such a broad organization. We don't have a sort of a coherent student group outside of APHA that would offer, a platform where you could have students come together and write white papers and publish them. That's a good idea. I mean, for us, blogging is clearly one way to do that, and use of the internet, use of social media makes it easier to get the message out now. But I don't want to fire you up too much here because I do want you to to develop the track record that you're going to need to be a credible voice. So, thank you.